Hi, I'm Ralph Preston, and every Tuesday we have our Stroke Buddies Recovery and Science Zoom meeting. In this meeting, we try and bring you valuable information on recovery, obviously, and the science behind it. Things that you can use in your recovery, of course. And today we have Dr. Samantha Amadeo. She's a neuro PT. She has her own business called NeuroThrive. If you want to contact her, all of her contact information will be in the description underneath this video. And today she's going to do a little presentation on common gait impairments after a stroke, and hopefully a little bit about how to fix them. And we'll have a discussion after. If you want to ask a question, unmute yourself and ask it during the presentation, and after she's done, we'll have a wide open discussion on anything anybody wants to talk about. So that's enough talk for me. Samantha, why don't you take it away, and feel free to share your screen whenever you're ready. And I'd like to ask you to unshare it after your presentation so we go back to seeing faces.
No
problem. That's it for me, so take it away.
Well, good morning, everyone. I'm Dr. Samantha Amadeo. Thank you for having me, Ralph. Today, our presentation is going to be really about the common walking impairments that someone can see when you've had a stroke. Now, some of these impairments can all come together one at a time. You can change as you're recovering. So we're going to really dive into some background on stroke and, how it affects gait, but then also explain what gait impairments can look like and really why they may be happening so that we can target them in therapy. So we'll go through a little bit of about me, gait cycle in terms, some common impairments following stroke, and then just some common gait impairments following stroke that are impacted by those impairments. So a little bit about me, I'm a physical therapist. I have my board certification in neurologic physical therapy. I have a wide range of experience. I worked in the acute care setting, which is hospital-based, rehab, in pediatrics, research, and then, I have a true passion for being a mentor and teacher. So I also run study groups for those who are training to be board certified neurospecialists. My business is NeuroThrive, Neurologic Physical Therapy and Wellness, where I provide virtual and in-home physical therapy and exercise program and rehab coaching. So my information will be below, but you can all feel free to reach me at my information that I have right here. So starting, we have a few things that we need to really understand about what the gait cycle is, because our therapists, our doctors, our orthotists, everyone may be talking about these things, but we want to make sure that we're understanding where we're having the problems or what everyone is even talking about, right? So walking is really described as when we're looking at either the right side or the left side. So if we're focusing on the right side or the left side, we're looking at 1 foot at a time. So what typically happens is we go into a stance phase, which is when your foot is in contact with the floor. And then we go into a swing phase, which is when our foot is moving through space, right? So it's moving through the air. So in stance, we're weight bearing, and in swing, we are not weight bearing. So when we compare the left and the right side between swing and stance phase, we can be looking at what is the left leg doing during swing compared to the right leg during swing, or what is the left leg doing when it's weight bearing versus the right. Now, therapists, doctors, orthotists, we all look at the timing. So are you spending more time on one leg than the other? Is it symmetrical? How far am I stepping? How wide am I stepping? How narrow is my step? Now, some big things that we see during stance that we really try to highlight is, specifically in stroke 2, is stance stability. So what that refers to is how strong and balanced and stable are you on your leg when you are weight bearing through it. So it's during that stance phase of gait. So you can see here, this is the stance phase. It takes up about 60% of our walking cycle. When there's weight bearing or any type of force going through this leg, your therapist and your doctors, even you will be evaluating how strong and stable are you able to put weight through this leg. Then we also look at swing clearance. So how well are you able to bring your leg through without it touching the floor? Are you overshooting when you're clearing your foot? Are you undershooting and dragging your toe and tripping? So that's another area that you may want to start thinking about when we're thinking about your walking. Then some other things that are kind of more global that we look at is speed, symmetry, and efficiency. So I'm sure many of you know by now that speed is very heavily correlated with fall risk. So when we measure walking speed, it's in meters per second. And if you do not walk more than 1.0 meter per second, when we do our outcome measures, you're considered a fall risk. And when there's a higher risk of falling, then we have higher risk of injury, higher risk of morbidity and mortality. So there's a lot of negative things that are associated when we walk very slow. So it's important for us to just even gather information about how quick are you walking. Then we look at symmetry and efficiency, which can kind of go hand in hand. So obviously with someone with the stroke, we'll see an asymmetry because there may be a hemiparesis on one side or loss of sensation on one side, but there are strokes that affect both sides. So, or, right and left, but right and left differently. So we do like to look at the differences between sides. And then efficiency is how much energy are you really wasting during gait. So the way that the body moves is really to be the most efficient walking pattern so that we're not using too much energy. Because when we're doing all these compensatory patterns to help bring our leg forward or to swing our leg or to maintain our balance, we're working really hard. And that's why we can become really tired when we're walking following a stroke because we have to work harder to bring a leg forward. So our gait following stroke is typically less efficient and more energy consuming than the typical person. Does anyone have any questions on that?
Part of being tired is when you're using this is theory that I've kind of confirmed. When you're using different parts of your brain like we do to be walking, it takes more brain power.
Yeah, for sure.
Especially in the early days, I felt a lot like I called it running out of brain. It wasn't that it was that much harder physically, it was that much harder mentally. So the concentration would get to your energy level as well.
Yeah, prior to having a stroke, your walking it's almost an automatic thing. You don't have to think about it. But when you following stroke, a lot of brain power, like you said, is you're relearning. So when we talk about motor learning as well, it's in that very early cognitive stage where there's a lot of thinking. It's like when you're first learning to juggle or write or this and that. There's a lot of, or driving. I think that's one thing that a lot of people think about is, or when I was even learning to drive, it's like, when is this going to feel just like a habit or, just like motor memory for me to just drive? And you're thinking about everything, pressing the pedal, turning the blinker on. When can I go? It's so much extra work. But once it becomes more automatic, there's less energy and mental fatigue, as you mentioned, Ralph.
I don't know.
Samantha, I have a question. I'm sorry, Ralph, I have a
That's okay.
question.
Go ahead. Go ahead.
Okay, Samantha, my question is in regards to what you mentioned about timing aspect, the timing of the gait. How can I, as a walker, when I'm walking across my kitchen floor, for example, how can I tell how fast or slow and what I am doing? Can I count to 3 seconds or something? How can I establish if my timing is off, if it's too slow or am not getting any better?
So what you can do at home to establish just timing in general is just to put on like a stopwatch. So if you have a stopwatch on your phone or you have a clock with a second hand, you can kind of see how long it takes you to move from point A to point B. So if you're looking at the distance of your kitchen or the length of your house or the length of your driveway, try to time yourself and see how long it takes you to do that. To
So
see
for
that,
for a goal, what would it be then? The goal, would it be 10 seconds to go that far? Or what do I do?
so it's going to be individualized depending on the person. So depending on the distance and the amount of time it takes. So say the distance of your kitchen is 15 feet and it takes you 15 seconds to get there, just try to decrease it, even if you're decreasing it by 2 seconds. A consistent 2 second improvement is good. When we're in the clinic and therapists are thinking about, if you're going to an insurance-based clinic or somewhere where they have to be reimbursed, or we're looking for even just truly significant change, there are all these numbers that we look at and like true objective values that we're looking at as therapists to measure. But for you, just to simply see that the time is decreasing each time is perfect. And just make sure you're tracking it. I think that's one thing that a lot of people miss out on is they miss out on a lot of the small pieces of progress that they're making because they're just not tracking it. So if you were to just time yourself from point A to point B and then keep working on that, keep working on your walking and then time yourself again, see how much better you get. And just make sure you're writing that information down.
A couple quick things.
Sure.
Everybody out there, including Mindy, be careful not to speed up and compromise your safety in any way. Also, you need to do something that doesn't involve you too much in the measuring because that's how you fall. When you don't pay attention is the number one reason that you fall. I haven't fallen in 9 years, but I pay attention to every time I even come close. And it's always when I'm screwing up, not paying attention, or trying to do two things at once. So your walking is important. Also, for anybody out there who's got like a Apple phone, I don't know about Apple has a health app that comes with it, and one of the things is measures steps. It also measures symmetry. Now they call it symmetry, but to me, symmetry means even patterning. They're using it the only thing they do is measure speed, but that'll tell you how far off you are with the unaffected foot and bringing it forward. In other words, we tend to bring that unaffected foot forward normally, and then the affected foot is typically slower, and it'll measure and tell you how much you're off. I don't know about Fitbits, but all the things that are walking trackers would really help with all this data, and they'll capture it over a half an hour walk, and you can look back at it. The other thing I would say is don't let going after speed affect your form, because form is more important than distance or speed. In my experience, speed comes with good form. And when you get back closer, back to that natural pattern, Samantha, I don't know if you've heard this or not, but my physical therapist, other people in the group have. My physical therapist said to me on day one, something that scratched my head and took me a couple hours to process it. She said, Ralph, we're trying to learn how to forget how to walk. Meaning back to that natural pattern, because we just do it automatically before a stroke.
Yeah.
Anyway,
Yeah.
sorry. I just thought I'd interject those things because they're
No,
important.
you're completely right. And I think when it comes to safety and trying to increase speed, sometimes I think I mentioned this in our last podcast, but sometimes when we want to challenge one aspect of our walking, we have to give a little bit of help in another aspect. So say we're challenging our balance, we may have to walk a little slower. If we want to challenge our speed, we may need to use an assisted device to challenge speed in that, if that makes sense, where if you really want to walk a little faster, we're challenging endurance, speed, distance. Let's give our balance a little bit of help so we don't have to worry about two things at once. And then same thing with the balance, you don't usually do balance training fast, right? So we're kind of giving up speed in the regards of doing balance training. So obviously try everything safe, just as Ralph said, especially if you're doing it on your own. However, if you're in the clinic with your therapist or you have a helper with you, caregiver, family member, friend, you could obviously give a little bit of extra, go a little bit extra into the challenge zone because you have those extra pieces of backup.
Or find a fence, like the outfield fence on a
Yeah.
park at a baseball field, outfield fence. What else have I found? We have on the water, so we have a lot of piers here that have railings, so they're really good. You don't necessarily have to touch it, but they're very safe places if you got
Yeah.
something like that, and
It's there just in case.
you want to keep it on your unaffected side, which means you need a nice long one because when you turn around and come back, it'll be on your affected side. That's not a problem once you get, some strength and movement back in that hand and arm. But if you got one of these, you can't do much with that affected hand in terms of safety. All right. Go ahead.
Well, sorry.
So find something where, okay, like a pier has them on both sides. Not everybody's got piers near them or docks. But there are some places where you can find stuff on both sides. I actually built a 216-foot. I built like a railing, 3 feet up with 2 16-foot 2x4s on top of 3 4x4 posts that I buried in the ground. So if somebody had a 32-foot walking thing and you could go around it. So you could keep going around and around like laps. But you have to have somebody that's willing to build that in your backyard and not live in an HOA where they won't allow you to do that or something.
Yeah, or simply you can, if you have a cane, just walk with the cane.
Mhm.
If you're balanced, when you typically don't walk with the cane, use the cane when you're challenging your speed.
Good point.
Something as simple as that. Or like Ralph said, finding somewhere where you can walk around in a circle. So even like if you're not walking a very long distance, you can just hold onto the wall in your house is just having that little extra piece of stability, like where you can, bump into the wall if you need to, or take a seat. Walking around even like a table, you'll have that, if we're thinking shorter distances, walking around a table is perfect.
Well, a lot of times just knowing something's there or being able to touch it quiets our brains after a stroke. A lot of this is fear. A lot of the issue with all this is that you have this underlying fear of falling. So just knowing something there often alleviates that. Touching it occasionally also does. So anyway, safety is important. Well, let's let Samantha go on, or Dr. Amadeo go on.
So some impairments that you may be struggling with following stroke are listed below. So we have weakness, difficulties with coordination, motor planning. So knowing, take my step forward with my left, now step forward with my right, or like planning out, putting when to pace the cane with those steps. Loss of sensation, whether that be, the feeling, touch, or, knowing where your body is in space. Balance and endurance. So now all of these are going to impact what our walking looks like, right? So it's not that we just have bad walking or difficulty with walking. There's a reason following that that's causing the issue. So we're looking to relate these things to the walking impairment. So I have here just your typical hemiparetic gait. So someone who has hemiparesis, or loss of strength or sensation on one side, a one-sided affected stroke, you could have some of these, all of them, or none of them. So really what we do as therapists, and what you can do as yourself, is really look at how you're walking or feel how you're walking and identify where that problem is. And then we're going to figure out why it's happening. Because you can have one problem that has 2 causes, 3 causes, or a problem that doesn't have a typical cause to it. So let me just see what I have next. Okay, so I have a couple of videos that we'll go through, but I'm going to go through each of these And I'm going to discuss that what could be the problem that's causing these issues. So in this picture, it's kind of a nice photo that we can really see what someone with a hemiparetic walking pattern would look like. So the first thing that we may think of or know very well is drop foot or toe drag. So now drop foot, what part of gait would this be in? So that's going to be during swing. So if you're noticing, so this is our observing, right? We're noticing that when we're walking, our foot is dragging on the floor, or we're tripping, or maybe our foot is just downward, right? It's just pointing downward. When typical walking, the foot is more upward, pointed upward when we swing our foot through. So if we're noticing that, we're observing that we would be identifying as a drop foot or a toe drag. Now, there's a bunch of different reasons why this could be happening. The most common is weakness in the ankle.
Can't lift it, yeah.
Yeah, so typically, I mean, a big reason that we have this is just like in the upper extremity, a very common way that we recover is proximal, or the closest to the body, to distal, or the farthest away. So typically the ankle and the hand come back last. Not to say that there are cases where they don't, but typically we have most difficulty with the parts that are farthest away. So the weakness in the ankle is very, very prominent in stroke. So to control the foot from dropping, the front of the shin is where the muscles are. So that would be a big reason for us to have drop foot or toe drag. However, I've seen many people be misdiagnosed with foot drop because of tone. So sometimes what happens, which I'm going to skip down to synergistic patterns, which many of you I'm sure have are currently going through or have gone through in your recovery, is when you start to try to do something difficult, your arm may curl up, or your leg may curl up, or you may feel really, really stiff, where that tone that you have tightens those muscles. During walking, because it is such a difficult thing, sometimes those synergies, those patterns that we see of tightening into like a curling up position or an extending out position can happen during walking. So it would look very similar to this, that what happens is a lot of extension happens. So we get extension at the knee, plantar flexion and inversion, so the toe going down and the foot going inward during walking, and a lot of tightness in the hip. Sometimes that will occur during walking as well, leading to the foot being in this downward position, causing a toe drag. So in that case, strengthening would help, but we may need to think about more tone reduction medications, uses of AFOs, which it would just be in a different type, or, different type of prescription than you would for drop foot. But that could be a reason why you're having some tightness or toe dragging happening during your walking. I'm going to continue on with the very similar and common issue that happens because of toe dragging or foot clearance issues. So sometimes what we see is we get really smart about our walking. And if we're having difficulty with some sort of a foot clearance during our swing, so we're having difficulty with bringing that foot up, we compensate. So there's a couple of different ways that we may be compensating, that you may see these or feel these issues before you notice the foot, or before you notice the leg being the problem. Someone may lean away if they're having difficulty with the foot. So they may lean away to hike their hip up to give a little bit more area for the foot to clear. Oops, sorry. They may perform a steppage gait, which is taking a really big marching movement. So you have what we call like excessive or increased bending at the knee and the hip, almost like you're walking through mud where you're pulling your whole leg upward. So again, trying to create more space for the foot. Or we can circumduct. So instead of stepping straight forward, we bring the leg in a roundabout way, to clear the foot. So you can see here, this like little arrow is showing that this gentleman is bringing his foot around instead of keeping it in line with his hips. You know, it would look sort of like it should be in line with this one where the foot would be on the floor here, but his foot's outward, right? So we're having a little abduction at the hip, outward movement, and circumduction where he's bringing his foot around so that he's able to clear. So trunk leaning, steppage, and circumduction may be because of a foot clearance issue, okay? So if you're noticing that you're having any trunk leaning, steppage, or circumduction, it's good for us to look down at the ankle and see, are we having foot drop and foot clearance issues that are causing that? And then we can go and figure out why the ankle is happening the way, you know, is acting the way that it's acting. But we have bigger issues than just an ankle, right? So sometimes the knee is impacted, the hip is impacted, our trunk is impacted. So trunk leaning is very, very commonly seen when there is hip weakness. So I'm not sure if any of you have heard of Trendelenburg gait or hip drop. So in a case where you're walking and your affected side, when you're taking a step with your affected side and your hip drops down. So say you're walking and you go to take a step with your strong leg forward, your hip may drop. To prevent the hip drop, we can lean to the other side. So this is called a Trendelenburg gait, or it's a link to let us know that there's weakness in the hips, where we're seeing movement in what we call the frontal plane, where you can see this gentleman, he's leaning, right? So he's leaning to one side, so we can have an idea that he may be having difficulty with a hip problem or hip weakness, and he's compensating that by leaning forward because he's got poor stability in the hip. Let's see what else. Okay, I just want to make sure that I'm not skipping anything here. Okay. Now, if we're moving down to knees, knee buckling and knee extensor thrust. So knee buckling typically occurs, we usually think of it as a weakness at the knee, at the quad, right? So our quad muscle that's in the front of the leg is what helps us extend the knee, right? That's what gives us that strong, stable leg when we're weight bearing. So right now we're kind of leaning into, so if we want to really divide this up, these first 1, 2, 3, 4 are really like more of a swing phase problem. So bringing the foot through. When we come down here to knee buckling and knee extensor thrust, that's more of a stance phase problem. So if we're thinking about affected side, in this case, the affected side is having difficulty with clearing or swing. We're thinking about the affected side with knee buckling and knee extensor thrust. That's more of a difficulty when you're weight bearing through your affected side. So now knee buckling, that's typically thought of as your quad weakness. So having difficulty maintaining my knee nice and strong, and then it gives out on me. Now, I actually posted a video about this on Stroke Buddies and on my personal, my business page about how knee buckling sometimes doesn't have to just do with weakness, but it has to do with muscle length. So we have an important muscle called the gastrocnemius and soleus complex. That's your calf muscle. And what happens is that calf crosses, so it controls both the knee and the ankle. So if that muscle is tight and we're standing on our foot and our foot is in contact with the floor, you can see here, it's gonna end up bending the knee and causing buckling because it doesn't have any more length. It's almost like if you're trying to extend a rubber band too far, it just gives out at one side. So if it's tight here over the ankle, it pulls on the knee and flexes the knee. So not only can we have knee buckling with weakness in the quad, but it could be due to length issues in our calf or tone in our calf. that's pulling us into knee flexion. So sometimes we want to look at both the strength and the length of muscles when we're looking at knee buckling. Unfortunately, sometimes when you're placed in an AFO, because it controls the ankle range of motion, so an AFO typically holds the foot in a neutral position, so you're not able to point your toe down because we want to work on clearance and stopping the foot from dragging. That can have a negative effect at the calf because it's tightening up over the knee and causing some buckling. So it really is a delicate balance between making sure that we're controlling an ankle with an AFO and not pulling too much on the knee that we're causing buckling. So it's important for us to look at both length and strength with the knee buckle. Now, say you're walking and it's not that your knee is giving out or you feel unstable, but you notice a really strong thrust backward where your knee feels like it's going really hard into a straight position. So it's almost slamming backward and hyperextending. That's what we call a knee extensor thrust. So you'll see this when you're moving from, you'll see here, what we call loading response into this position, which is like mid stance. When you start to load the leg, you'll see a quick snap. So when you're going from here to here, the knee snaps backward. So you may feel some tension in the back, some pain in the back of your leg, or someone will say like, oh my gosh, your walking looks painful because the knee is really just snapping back. Typically, that's caused by, so we have both muscles to control our joints, right? But we also have like ligaments, joint capsule. There's a bunch of things that give us stability at our knees and all joints. Typically what happens is we can use our knee extensor thrust as a compensation for weakness. So we may have difficulty with control at hamstrings and quad. So we're just relying on like our ligaments, our capsule, all those more what we would call like a non-contractile tissue. So it's something that isn't a muscle, bone, just the extent of the joint to give us stability and stance. So instead of buckling because I'm weak, I'm just going to throw my knee back and I'm just going to get nice stability from having my knee in pure extension. Sometimes what we can see too with knee extensor thrust, more of a proprioceptive or a sensory issue where we're having difficulty with understanding where our knee is and it's almost floppy. So there's no control. There's poor motor control at that knee. So typically what we do with this is we really work on slow and controlled movements in and out of the range of motion. So very, very slow mini squats or backwards and forward stepping in a very slow manner where we can feel the position of the knee and try to control the extremes of movement. So we don't want to go into full tight extension and we don't want to be falling into knee buckling. So we're trying to get a balance between the knee moving, basically the knee locking and unlocking for stance stability. So typically you'll see that either they have a control issue or like a sensory loss issue, in addition to some weakness with a knee extensor thrust. Now, lumbar lurching, this may be something that not many of us know the term because it's not really something that we see in the lower body, but you'll see it in the trunk. So when someone goes to try to bring their leg forward, typically we have a weakness, right? So the whole leg can be weak, but we can have difficulty with pushing off with our toes, difficulty with kicking the leg forward at the knee, or bringing the leg forward with the hip flexor, right? That muscle right in the front of the hip to bring the leg forward. If we have a tough time with bringing it, we almost use our back to fling our leg forward. So you'll see someone lean back right before they swing their leg forward, and that's lurching their back to get momentum to like swing that leg forward really fast. So if you feel like you're really leaning back, you're having a little back pain when you're walking, you may be lurching. So we want to make sure that we're getting good strength and momentum throughout the entire leg to get that leg forward. So you may be seeing like that impairment at the back, right? Funny trunk movement, but it's actually because of weakness at the leg. So now kind of switching, arm swing. If we have
Yes, yes, yes.
if we have hemiparesis, that arm is not moving the way we want it to. Either it's flailing or it's tucked in a synergy pattern or it's moving way slower than we want it to. And then also, we may be using a device that's limiting our arm swing on the other side. Now, arm swing is super important because it helps us with the rotation of walking. So we kind of twist a little bit. Our pelvis rotates, our trunk rotates. We're not just kind of stagnant creatures where like the whole top of our body stays still and just the legs move. So when we don't have arm swing, we really don't get the trunk movement. We don't get the rotation through the trunk and the pelvis. Our speed goes down, our ability to balance goes down. So this is obviously an issue that could be due to just the arm in general because of either flexor synergy or the paresis, having weakness in the arm where it's kind of just hanging. Or it could be because we're using a device that's unilateral on or only on one side, and we're not getting a good arm swing. So if we're noticing that we're having difficulty with rotation and arm swing, it's good to do, just in general, some stretches for your back. So trying to get rotation otherwise. So if you're in a chair, trying to rotate back and forth, reaching left and right behind you, or even just in standing, trying to twist your body. It can be difficult to improve arm swing if you have like a flexor synergy in your arm, or if you have paresis. But sometimes what you can do is stretch beforehand. So for someone, we'll talk first about someone who has a flexor synergy like this man. What you can do is stretch first. So if you can get some of this tone to reduce prior to walking, that would be helpful because now the arm is in a more relaxed position at the side of your body. Then you can try to just swing your arms in standing before you actually take steps. So it's almost like you're swinging your arms left, forward and back when you're standing, or you can like almost march in place.
I have a
This would be
video
helpful.
on exactly that. I'm doing it at a counter on my YouTube channel. I'll drop it in the.
Yeah, perfect. Where you're trying to really get the left and the right moving, not equally, but somewhat equally, where you're getting that trunk moving, and it could all be coming from the trunk. It doesn't even have to be coming from your arm if you're having difficulty with active movement in the affected arm, but really just trying to incorporate that into your walking. When you have a synergy like this, trying to maintain the elbow and more extension will also help. So if you have something like an air splint, something that's splinting the elbow to keep it downward so that we have it at the same area as the unaffected arm, that's also helpful. But something if you are able to get manual therapy or occupational therapy, like your physical therapist could work on this with you, or your occupational therapist, where they're able to work a lot on the shoulder blade. So to get movement, a lot of the tone resides in the shoulder blade. So if you're able to get some relaxation and movement within the shoulder blade, sometimes that also improves the swing. Now, in a case of when you have more paresis in the arm, again, you can use something like a splint to control excessive movement at joints. So we could have a floppy elbow, a floppy wrist. So if we were wearing something like a splint, that can help with preventing excessive movement. But we have a little bit of concern for the shoulder. So typically if you have paresis through the shoulder, you'll have a subluxation or a lot of pulling at the shoulder. So what I would recommend is wearing something that's placing the arm in a comfortable position while still giving some what we call approximation of the joint. So allowing the upper arm bone to sit better within the shoulder joint so it's not hanging. One of my favorite things is the Give More sling, or you can wear something like a proximal shell swing where it really is just up here. You may see someone who has like a shoulder, I'll escape here. I'm not sharing, right? Can you see my screen, Ralph?
No,
No, right?
you clicked out, but while you're
Okay.
finding it again, I'll just
No,
say,
it's fine. I want to show the sling.
yeah, the Give More splint holds your arm down by the side, and instead of, as you know, Samantha, this whole cross pattern thing is a stroke pattern.
Yeah.
You don't want to play into it. So I was going to say you don't want to wear a sling. They're
Yeah,
just,
not a sling that's up here.
yeah, they're designed for injuries, and you don't want to immobilize that arm, particularly in a in a stroke pattern. What if
Yes,
you have
yeah.
a sublux shoulder, you want a brace that holds your shoulder up here and allows you movement.
So this is what the Give More sling is. So
Yep.
you can see here, it gives a little bit of support to the elbow. It keeps the hand nice and open. So there's, let me see if you can, it's almost like a little plastic handle that you
Just
place within the palm of your hand.
right.
Goes over your shoulders like a backpack, like you can see here. And it allows the shoulder to sit nicely together versus just hanging downward. Now, this will give a little bit of control when you're walking. So when you're, so you can see here, it's like almost like a little tubing that you place your hand in, where you'll be able to kind of get a little bit of, this woman's wearing two, so you can kind of see the handle here. You can get better control and the arm in a nice position while you're actually walking. Now, there's also, so this is what me and Ralph were saying, do not get something like this because that's going to just lead to contracture in the elbow. It'll make that bicep super tight. But let me see. This
Yeah,
is kind of similar to what I'm trying
but
to,
there's a brace.
yeah, so this is called like a proximal shell sling where it really is just pulling the shoulder upward to keep that subluxation or that little bit of dislocation that you may have because of weakness at the shoulder together. So it protects the shoulder joint. There are different ones that you can get, but as long as, here's a nice one, where it's really just holding the shoulder upward to protect the shoulder joint while you're walking. Here's another photo. So that may be something that you could be interested in trying when you're walking. Additionally, I'm going to go back to my PowerPoint and show you. I'm going to go back to where we were. Oops. Let me put it in presenter mode. So in addition to reduced or absent arm swing, something that you can try is using, so say you have a little bit of arm movement, but you still need, so you have the ability to grasp or hold on to something, you can try two devices. So you can try a cane on one side and the other side, because the cane, really placing the cane outward is like faking your arm swing, right? Because it's going with the opposite leg, which is what we typically do when we walk, like opposite arm, opposite leg will swing. So if you had something in your opposite hand, you know, in the affected hand, if you're able to hold on to something, that'll, in this case with this patient, would stand him nice and straight. So we'd get rid of his trunk lean, right? He'd be weight bearing through both arms, which weight bearing through the affected arm is very helpful. And then also you're going to get some rotation at the trunk, and the arms will be moving in that reciprocal movement as you walk. If you're further, you know, if you're more early in your recovery and you don't have that, using something like a walker is nice because at least it's helping you get upward and it's putting the arm in a nice position to kind of prep for reciprocal arm swing. So it's like you're not there yet, but we're still going to get a little bit of weight bearing. We're going to get better symmetry at the trunk, which will lead to symmetry with the arms. Finally, we'll go back into synergistic patterns a little bit more. You may just feel some tightening and almost like a unilateral, so a one-sided steppage where I was mentioning before that the leg could extend into plantar flexion and inversion and tightening at the knee. Your synergy could also be in flexion where you get a little bit too much hip flexion, knee flexion, and ankle dorsiflexion when you go to try to step. So it's almost like you're overdoing it because the leg is tight. Now, just trying to dissociate or make each joint work on its own is helpful in breaking synergistic patterns. So what happens is hip, knee, and ankle all turn on at the same time during a synergy, or shoulder, elbow, wrist all turn on at the same time during a synergy. So to break those patterns, we try to get isolated movement. So for instance, just say we're in sitting, just kicking the knee without lifting the hip, just moving the ankle without moving the knee, trying to maybe do, for instance, if we're trying a bridge on, we're on a mat or we're on our bed and we're trying to bridge our hips up, making the hips go into extension while maintaining knee flexion. So your whole body isn't being thrown in extension at once and then flexion at once. We really are trying to break those joints apart so that we're able to piece them back together, because with this synergy, they really all work together. So what I have for you here is a few different, I think I have like 4 videos of some walking patterns where we can really see it and I can point out to you. So if you feel like you look like one of these, you can kind of pinpoint what may be going on with your walking. Let me just take off let's see. So this patient, her left side is the affected side. Now, what she really has, what I would look at first is her swing. So look what her leg is doing when she's bringing her leg forward. After you look at that, then look at what her leg's doing when she's weight bearing through that leg. This is the left leg. So I'm going to pause here. In this position, her ankle should be up more. So she's a typical drop foot. Now, she's not having difficulty, right? Like she's bringing the leg forward, but it's not as nice as we'd like it to be. So working on some ankle strengthening here would be great for her. Now I'm going to pause when she goes into stance. So right here, try to look at her movement when she's moving from her foot just touching the floor to when she gets into this position. See how fast it happens. So it's here. Right there. You see that? How quick that happened? So ready? Slow, 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 and boom. She extends very quickly. So she has also an extensor thrust going on at her knee right there. You can almost see like look at her pants on this side. And now look how quick her pants move here. See the difference in the pants? Pants nice and quiet. And then her pants here move a lot. So she gets an extensor thrust on that left side as well. So working on her knee, proprioception, and control would be helpful.
Weight bearing too.
Yes.
She's possibly trying to get off that unaffected foot as quick as possible.
Yes, that could be it too. So that timing where we would be looking more so at how quick she's moving. I would say the rate at which the knee is moving backward is the extensor thrust, but we want to see the timing, Ralph, between this step 1, 2, 3, 1, 2, 3, 4. So there is a difference in, yeah, there is a big difference in how much time she's spending on each leg. Now, I think we do get, so in this video too, you can see it from the front. So again, that left leg is the one that's the problem. Okay, so you see the stripes, how they're
Sticky toe.
tilted. Say it again, Ralph.
She's got sticky toe.
Yeah. You can see, look at the stripes on her back and then look at the stripes here. She's standing on her weak leg and the hip is dropping down, right? So you can see that the stripes in her shirt are tilted downward. So that's showing some weakness in this left hip. Ready? So she's nice and stable here, right? Stripes are straight and now look, stripes dip down right there. Boop. So she's got a little bit of weakness in her hips too when she's in stance. So hip abductors, so kicking outward to the side, those muscles that kick outward to the side would be something good for this woman as well. She's got good reciprocal arm swing though. Left and right arm are moving. But you can still see that foot.
Puts it down flat.
Yep. There's no heel strike there. This one's nice heel strike. So
Couple times she did.
yeah, she's a little inconsistent, but she's a perfect example of like a high functioning, a very good walker, like a functional walker, but still has some gait impairments going on. This patient, oh, this is the same one. Okay, this is the next guy. Okay, so he is a right hemiparetic. So you can see his right side is the affected side here. So let's look at swing.
Very little knee bending.
Yeah, very minimal knee bending. So he's probably has some weakness in his hamstrings or has a little bit of tone happening. Can you see? I mean, we'll be able to see, I think he goes from the front. Let's go to the front during the swing. He's got some circumduction, right? So his legs swinging around.
Got his toe pointing out slightly too also.
So you can see on that right side.
A little big circumduction.
And
much?
he's got like a very floppy, uncontrolled ankle. So he's probably, so the first thing we saw, right, was the circumduction. But it's like, why is the circumduction happening? Probably because of his ankle, where he's trying to help clear that foot, where you can even see when he walked in the other direction, that toe caught, right? Look at how his foot kind of goes into plantar flexion and inversion, right? It's kind of bleh.
He doesn't do a big body lean, but look at his left hip go out slightly.
Yep.
He's hiking that leg by dropping his left hip.
Yep, you're completely right. Where you can see the hike
I've watched,
there.
I was always scared of doing this, but in the last 5 years, I've watched 500 videos. People ask me to analyze their walking. You actually have to watch them about 10 times. You have to watch the ankles. You have to watch the foot drop. You have to watch the knee. You have to watch. And in the beginning, I didn't get people to send me full head to toe. And I started realizing that you really need head to toe, not just legs and hips.
Now let's look a little bit at his arms too. So right side is the affected arm. What's the right arm doing?
Behind. No, now it's leading.
Yeah, so he seems to get a pretty good arm swing, but I'd say it's a little inconsistent. It's a little more flaily and not as controlled as the previous person that we saw. So it's not as controlled, which could lend itself to, you can kind of see in these videos, he's got a little bit of like the bicep is a little tighter on that arm. You can see there's less control in this right arm than there is in the left.
He's crossing it a little bit. It wants to go into that stroke pattern.
Yes.
He's still fighting that.
Yeah. It seems like he has a little bit of shoulder, like see how his shoulder is so dropped? Weakness in the shoulder.
Yep.
And the scapula, if the scapula is protracted, so it's coming a little bit more outward this way, that can bring the arm in front of the body as well. He actually even trips in this a little bit. You could see in this clearance here.
It's lower than his left shoulder.
Yep. Okay. So now I included this YouTube short, which is in a taxic gait. So we didn't really touch too much on incoordination, but incoordination is a very special type of walking that will happen with a cerebellar stroke. So anything that's more brainstem will be more ataxic or uncoordinated, but it's different than difficulty with motor planning. So we may see difficulty with smoothness of gait or the timing of left and right, but it looks a lot different when it has to do with cerebellar lesions or strokes. So I just wanted to show you guys this so that if you were to do any research and you see ataxia, but you didn't have a cerebellar stroke, you're 99% don't want to be working on what we would be working on with someone with cerebellar ataxia, because it's just a different part of the brain that we'd be targeting. So he really looks super unstable, where he's got a very wide base, right? His feet are so far apart. And it's almost like he's trying to quickly step to the ground so that he doesn't lose his balance.
I've worked with a couple of people with cerebellum brainstem strokes, and they often present on both sides.
Yes. Yeah. Maybe that would be, Ralph, a good topic for me to cover next, is going through cerebellar, because they really present so differently, and it could just be if any of you are interested, let us know. That it is a very detailed and different type of stroke and different treatment approach than someone who has a hemiparetic stroke that's typically caused by like a stroke within like the frontal or temporal lobe, parietal lobe, where it's the motor planning, the motor cortex is affected versus the cerebellum. Okay. Now this is actually a someone acting as, they're just trying to do what a hemiparetic gait looks like.
Patients with a circumduction gait are.
So she's showing circumduction, but the reason I like this is because of how stiff she made her leg. So it's different than the circumduction that we saw from the last one, right? So now patient A that we saw circumduction. Now patient B, we also see circumduction, but the cause of the circumduction could be different between the two. So the first gentleman that we saw in this video, we lent itself to weakness right in the foot. So he was having difficulty with foot clearance and foot drag, which was most likely due to weakness, right? So you know how we're kind of working backwards. We saw circumduction, then we looked at the ankle, we saw that there was weakness, we saw that there was toe drag. Why was there toe drag? It was because of weakness. Versus this, look how stiff her whole leg is. So she's just acting, but her arm is stiff and the leg is stiff. So we're seeing circumduction, we're seeing the foot in plantar flexion, right? However, the reason that she's probably having difficulty with foot clearance and circumducting is because of an extensor synergy. So this would be due to tone difficulties versus strength difficulties. So two people, same presentation, but some other reason why they're presenting that way.
Question, would you have her, I'm trying to learn, always be a better physical therapist, which I'm not. When I see this, I get people to weight bear until they can get that heel down on the ground.
Yes. However, she may have difficulty with placing her foot into weight bearing because it depends on why she's having the tone. So the tone may be due to she's working really hard and it's just turning on when she goes to walk, Or it may be due to she's kind of like has static tone or like a contracture almost, where the foot is just remaining in plantar flexion the whole time. So in this case, Ralph, I'd say yes, because she's remaining in plantar flexion the whole time, even when she's weight bearing through the toes.
Right.
So that would be a good reason for her, a good intervention for her, because we'd want to get the heel down to the floor, where we could do a lot of weight bearing or closed chain, you know, working with the foot on the floor and getting the ankle moving and the knee moving on their own without the tone. If she were to be able to kind of get her foot to look like the unaffected side um, during stance, but then all of a sudden tightens up during swing, then that would be a you know, a bigger fish to fry, because now it has to do with the body just going into a synergy when it's walking. So again, we try to break the synergy, but it's just a little bit more difficult, and weight bearing would help, but she wouldn't be having a weight bearing problem. It's more of like the minute she puts any effort into something, the tone comes out. So that may just be we wait until the tone starts to improve, or we look at tone medications and stuff like that. Does that make sense?
Yes, thank you. I learned something. I learned the difference. I mean, where you would and where you wouldn't.
Yeah, because sometimes tone is just there all the time, and sometimes it turns on. So it's like what we call the synergy pattern, you know, versus like a resting tone where the arm is just tight and held, or the leg is just tight and held together. This was another really good video. Let me see. Where does it start? I like this video because the gentleman's walking with a device. So now we get to see someone who has issues just like the other folks, but now he's actually walking with something. So we can see almost how the device causes him to lean to his unaffected side, right? I mean, we can just see this in standing, right? Look how much his trunk is going to one side and how uneven his weight bearing is between his legs, right? So the use of the device obviously is helpful, but there are issues when you introduce a device where there's going to be some unequal weight bearing happening.
Cane's too short.
Yes, that's for sure.
I've
Look
never
how
seen
far
one
he's
that
putting
big.
that cane. Look at that. Doesn't that make you cringe, Ralph?
Yes.
Going back to this.
You want to try and maintain it as close to an erect posture as you can.
Mm-hmm.
He's doing that because the quad cane's so big, it's like a hemi walker. I'm
Yep.
not a big fan of hemi walkers. You know, you get that big step ladder over there and you got to get out of its way. And it makes it forces leaning. Anybody
Yeah.
who's on a hemi walker, my advice, and Samantha's the PT, not me, would be to talk to your PT about when you're able to move on.
So the therapist did increase the height of the cane, so you can see the difference here. But at that point, he's barely using it. Typically, I mean, this is just an aside, quad canes are very interesting because you really should only have a step 2 pattern, like a walking down the aisle pattern where one foot comes and then you meet the other foot, because all 4 prongs have to be on the floor at one time. So doing like a step 2 pattern, he's kind of doing the step 2 where he's able to put weight bearing through the whole quad cane is the best way of doing it, but it does slow you down a lot, gives you asymmetrical step length. You don't have the reciprocal movement anymore, and again, unequal weight bearing. So the therapist actually brings up the cane, but we're still seeing difficulty. But let's look at his walking, right? So look at the leg as he's bringing it through. He kicks it out to the side, right? We're seeing some circumduction again. See the little circle? Whoop. So now why could the circle be happening, right? His knee isn't bending.
Right.
So the
No,
leg is
but
definitely long. The ankle isn't moving at all. To me, I mean, related especially to the upper extremity, he definitely has some tone going on here. Little different than the other when this woman was having the foot in plantar flexion the whole time. He doesn't have a plantar flexion issue, but oh, why is it not playing? No, it was just working. Maybe if I exit out and try it again. There we go.
Up a wee bit high.
So it seems like it's more of a tone issue with him. Now the therapist ends up putting on an AFO and a hand splint on him. So this looks like to me, let me see if I can see before they put it on the AFO, what it looks like.
Mhm.
It seems that it's just what we would call a posterior leaf spring AFO, where it's just giving him some help in dorsiflexion. We're not really going to get much control at the ankle.
No cane.
No
He didn't
cane.
like it. He didn't like it. Oh, he's doing pretty good.
So he's definitely leaning to the right side more, right? So he's more equal. The shoulder is weak, right? Because it's kind of like leaning down. But look how much better his circumduction is. Very minimal.
Not much knee bending though.
Yeah, knee is still very stiff. He definitely has some tone at that knee where he's not bending it at all. But it's interesting to see how much more improvement he has with just getting rid of the cane. So you would think sometimes someone would look better with the cane because it gives them more stability. But some cases the cane, it's really so individualistic that it really all depends on the person. Now I feel like I just chit-chatted for 8,000 years. So does anyone have any questions, any comments? Ralph, if you have anything you want to input?
Yeah, I made a note. One thing, there are multiple ways that you can have hyperextension. You mentioned the gastroc and also the quads. What I did was at the counter, I did heel raises,
Mm-hmm.
and I did them on my affected leg only. Very difficult. I can
Yeah,
only
that is a
do
very difficult movement.
5 or 10. I can do 200 with both legs. Well, I stop at 100 or 200, no problem. But doing that affected leg only, if you think if you think when you're doing with both legs with equally, try it with your affected leg only, and you'll be in for a big shock because you're basically using 80% or so of your unaffected leg to push up.
Yes,
So
yeah.
that's one thing I did. I also did really shallow knee bends, and I also did them only on my affected side. Really, really shallow. You just come what I was trying to do. I figure everything out by logic. What I was trying to do is I noticed that I had pretty good control till I got close. So what I did was work just real close over and over and over again, teaching myself where that point was, where I had to stop before it started that bit of a snap.
Yes.
And so again, I can do about 30 deep knee bends before I want to rest. I can only do 4 or 5 on the affected leg only, and you don't need to go that deep. One solution to this is if you have access to a pool. When I was going through this, I had access to a pool, and I found that while I could only do 5 heel raises on land, I could easily do 50. And same with the deep knee, with the shallow knee bends in the pool, I could do however many I wanted. And both of those are really good to get enough repetition in, because when you only have 5, number 3 isn't great, number 4 is falling apart, number 5 you realize, oh, okay, time to stop. You don't want to pattern your brain in a bad or negative way. So I found the pool, being able to do like 50 at a time, really helped with a lot of positive brain patterning and the reps you need.
Yeah, I was going to say high repetition.
May I ask a question about that?
Sure.
You're isolating your affected leg or affected side in the shallow knee bends only by raising up on your toes, or how are you isolating that affected side?
Well, when I did it two ways, raising my heel up onto the toe, that's a heel raise, and also with standing on that one leg, weight bearing, and doing a very shallow, just lifting the other one off the ground, doing a very shallow knee bend, very, very shallow,
I see.
almost to standing, just working those 2 or 3 degrees right before it
Yeah.
locks.
And
I'm
Stephanie,
going
you can do
with-
that with both feet on the floor too. Or if you feel unsteady, to do it on one foot. I mean, Ralph used the counter, I'm sure, but you could always put your affected leg on a step where you're raising the other foot up, where that really just inherently increases weight bearing on the other side. So it's not that you're totally weight bearing on one side, but you're putting most of your weight on the affected side that's on the floor.
So just by raising
Just by
the
raising the affected.
healthier leg, then
Yes.
I'm bearing the burden. Okay.
Yes.
Yeah,
A lot of people practice like
steps-
sit to stands with that too, where the foot's either out to the side or on a little small step, so that you
Okay.
really have to weight shift more towards the affected side, the one that's not on the step.
I really belong in that first ladies gait disruption, mostly proprioception of the spine and over and stability. And so working those edges, if you will, because
Yes.
of the knee extension, which is not nearly as bad now, but I find a big trunk deficit. So I'd really like to kind of focus in on that.
Well,
Yeah,
you're
for
more
sure.
you're more than halfway there, in my opinion, because you realize what's going on with you, and therefore you can take a focused approach. Most people don't have a lot. Some people don't have a lot of body awareness, and they're not paying attention like you must be to be aware of that.
Well,
And
this is really great, but Samantha, are you out of New York City? Are you in?
I'm in New York City, yes.
Yeah, finding practitioners in some areas are just it's very difficult to really get somebody to take a really detailed look at gait patterns and what you need to be working and sort of
Yeah,
isolating that.
that, and not to put it a plug for my business, but that's really why, even though I do work out of New York City, I do the rehab coaching and exercise programming virtually, so that I'm able to provide, it is cash-based because it's out of New York City. However, it does give me the ability to provide care to people who are in different areas. I actually have a patient right now in Africa. So
That's fantastic.
yeah, so it's
I
really
noticed some
fun
of the
because,
attendants are from Africa, so.
yeah, so it all.
So Samantha, would that mean you meet with somebody in person and then develop a program and then they continue virtually, or is that
It could all be virtual,
okay?
or it could be half and half. It all depends. So if you're, say you were within my area and I could travel to you, then sure. But typically it's all virtual.
Okay,
Yeah. And then
I
if you have
have
any questions, too, you can reach out to me.
okay.
I have a question, Samantha.
Sure.
You mentioned during your presentation something about, this will not be a popular or a question, but I'm wondering about it. Curious, I guess, about the medicines that might be for tone. Now, what were you referring to? I have a doctor appointment tomorrow. I was just curious what you were referring to when you said maybe medicine.
Sure. So very common, I mean, I'm not a neurologist, but very
Mhm.
common medications that someone can be placed on for tone are either muscle relaxers or like a nerve pain medication. So those are typically like baclofen, gabapentin, Neurontin. These are all words that you may hear, that those will reduce the tone in muscles globally. Because it's an oral medication, there are such things as a baclofen pump that can be, it's a surgical placement of like a pump into the spine. that's more for someone like with MS or Parkinson's, where they have very, very severe tone and rigidity. But those are global medications. So sometimes people don't love that because they'll feel tired. It goes to their other muscles as well. So those are very typical ones, but there is also Botox injections, which are site specific, where your neurologist or whoever is administering the medication, they basically inject Botox into the affected muscles. So say you have very, very tight calves, they could place the medication there, and they can maybe use some in your biceps or in your hips, depending on wherever the problem is. So it's just more of a medication that's specific to an area versus a global medication.
Thank you.
You're
And
welcome.
the,
Hi there. So I have a question, please.
Sure.
Sure.
And I apologize if I'm taking, I don't know if this has already been addressed, because I joined a little bit late. I'm just wondering, because I'm trying to understand what the definition of tone is.
Okay. That's okay. I did see, I was just gonna actually answer your question, T, because I saw
Oh, thank
you,
you, Samantha.
I saw that you messaged in the chat. So if you, I do have a graphic of this on my page. So for anyone who wants to go to see this afterwards, I have a little bit of like little graphic that I made on my physical therapy practice Facebook and Instagram page if you want to access it. But basically, every muscle in our body has resting tone. So tone is like the resting contraction of a muscle. So even when my arm is relaxed, my bicep, every little muscle that I have has a little bit of a contraction happening in it. So what happens is that resting contraction in the muscle is affected with stroke. Typically, with a neurologic injury, either to the brain or spinal cord, we have hypertonia. So that means too much tone, where there's really like strong tightness in the muscle. So the muscle at rest is too much contracted. So that's where you'll see the arm pulled, the leg pulled into a position that if you try to stretch it, it feels so strong to try to stretch it. It's like stuck in that position. In other
Okay.
conditions like Down syndrome or a lot of like the pediatric conditions, there's low tone or hypotonia, where the muscle contraction at rest is very low. This is more typical with where you have the flaccidity in the beginning of stroke, where you have paralysis or very, very low, lower tone in the muscle, where it's really just like kind of floppy. So it almost feels, if you were to feel your muscle on one arm compared to the other, it almost feels like the muscle belly is very, very squishy. And that's because the contraction at rest is lower. So as you move through your recovery with stroke, typically tone will increase, where it's almost like a bell curve, where it'll increase and it could be really, really strong, and then it comes down and reaches more normal tone. However, not every person has tone, and not every person goes through the entire bell curve. So some people get stuck and they're always low tone. Sometimes they get stuck and they're high tone forever, or they start to recover and it's like moderate amounts of tone. So it really depends on the person and the type of stroke. But that's really kind of what tone is described as.
Okay, thank you very much for that.
You're welcome. I did see one other question about like the reciprocal arm swing affected using a cane by Judy. Yes, I think I targeted this, but let me just rehash it a little bit. You can definitely work on your arm swing while using a cane in the other hand, just by trying to get some movement in your trunk and swinging in the arm. It doesn't have to be anything dramatic. Like some people walk, power walkers, and they're like, doesn't have to be like that. You can just do a little tiny bit of movement where you're getting a little bit of rotation with the shoulders and the arms are swinging a little bit. If you did want to try, you could also do walking sticks. That's very helpful to get some arm swing, or you can do it in place, like what Ralph was mentioning earlier, just marching in place and getting the arm moving so that you don't have to use the cane.
I don't know if he's still here, but I sent a video to the guy that was asking about that.
Okay, perfect.
Also, Samantha, you're talking about follow-up subjects. One that can't do too much on is tone, spasticity, hypertonicity, and another one, it could be ganglion, or a separate would be going through the 7 Brunson stages.
Okay, that
I
sounds great
I
too.
would assume you know something about the
Yeah, yeah.
Brunson stages.
Yes, I
If you
do.
have a doctor of physical therapy, probably more than I do.
But you know what? Even if you know a lot or a little, it's really those basics of understanding so that you can, I feel like a lot of stroke recovery is just understanding where you're at and having a not real, not just realistic, a positive but realistic understanding of where your progress and prognosis is headed, because a lot of it can be questionable. So understanding what to expect is so helpful just in like calming that anxiety. And this happened to me, that feeling of being a victim, it gives you a little bit more control when you have that knowledge.
I have
Plus,
a question. I'm sorry.
go ahead.
Sure, Denise.
Yes, I'm sorry. I have a two-part question. Do you think that, because I feel weakness in my legs, do you think that exercising, like weight training, exercising on my legs would help? And also, I also have vertigo, and my balance is off already, but with the stroke, I still feel off balance when I'm walking. So do you have any suggestions on what I could do to strengthen my legs, and would that help?
Yeah, so I mean, I would have to look a little deeper with you about like what's causing the weakness, like what specific muscles, but any type of exercise and weight training is going to improve your strength in general, because the more we use it, the stronger we have to become. It's like that, it's what we call like Wolf's Law, or where if you're using something more, you're going to get stronger at it. That's basically why people get stronger and their muscles grow when they start to weight train, is because you're putting more stress, so the muscle responds to that and starts to build and grow to take over that, to be able to, what's the word, like conquer that stress on it at later periods. So it's like adapting to the need. So if you're just sitting and relaxing all day, the need on the muscles in the body is very low. But if we increase how much we're relying on those muscles, then they'll definitely improve. Now, with the dizziness and vertigo, again, depends on what's happening with it. So vertigo is really just a symptom. A lot of people use it as a diagnosis, but there's a reason why we have that feeling of dizziness, that room spinning.
Mm-hmm.
Could be due to peripheral vestibular issues, which is the ear,
Right.
which is very common in older age. It's very common in general, but also it can be due to stroke, specifically more lower strokes, like in the cerebellum, the pons, brainstem strokes, because of just the area that they're in, which can lead to the room spinning. So really the approach to targeting those, they can be targeted. It's just a different approach. So yes, there's definitely interventions. It's just more specific. And I don't want to go too deep into it. Maybe we can do another podcast about that later on, or you can reach out to me personally. But with balance, we get a lot of information from our feet and our muscles and our joints about where we are in space. So if you have any loss of sensation, or you're not weight bearing as much through one side, the information that your brain's getting about where you are can be fuzzy and not strong. So the more you do that, you're going to give your body more information about your balance. But there are ways to train balance by challenging the sensation you get through your feet and your legs. So walking on uneven surfaces, walking in multiple directions, walking while turning your head, or doing something with your hands, like like throwing a ball up and down and catching it, or texting on your phone, holding a cup of water, challenging like a dual cognitive or dual physical task. So it really all depends why the balance issue is happening as to why you would be intervening or how you would be intervening. But again, that all really depends on how you present individually. So I'm trying to give the most general
Right.
too, but we can dive a little deeper if you'd like, if you want to reach out to me.
Yeah, I think my vertigo is mostly from my inner ear issue, but I still have balance after the stroke when I walk. And sometimes I feel just totally off balance. So I was wondering if I need, I got some information from what you were saying today as far as swinging my arms, but I was wondering if I also need to strengthen my legs, if you think that will really help improve my balance as well.
Yeah, for sure.
Yes, okay.
Because all of that sensory information of where you are comes from the feet. So if you're working on your legs, you're working on impact. So you're like marching hard. You're giving a lot of information up through the body to the brain to know where you are in space. And like I said, you can even work on different surfaces. So walking on grass, gravel, sand,
Okay.
shoes on, shoes off, socks. The more variety, the better.
Okay. All right. Thank you very much. That's
You're
very
welcome.
yes.
One quick thing, then we'll come to Judy, who's got her hand up and been very patient. And that is, it won't fix your balance, but having a good, strong core, I've found is important to everything. And in case of balance, well, you can work on proprioception also. That's your ability to know where you are. One of the things, if you don't want to fall, is you have to have good proprioception. The better your proprioception, the less likely you are to get someplace wonky. But having a good core will allow you to pull yourself back to center, back to that string coming above your head. Plus, core has to do with everything. Won't fix balance, but I encourage everybody to work on core. Your arms, your shoulders connected to your core. Everything is connected to your.
Yeah. You have to have stability to have mobility.
All right.
Really
Okay.
like the best way to say it.
Yes. Thank you.
So you don't disagree with that, then, Samantha?
Oh no, I don't disagree. I think that's huge soapbox that I could stand on forever and chat about.
I shouldn't be playing physical therapist in front of a doctor of physical therapy, but
listen, you know more than some physical therapists. Let's put it that way.
What?
You know more than some physical therapists, so.
Yeah, I wouldn't say that, but I wouldn't argue with it. I personally wouldn't say that. So wouldn't argue with it. And it's important to me to try and be doing the right thing when I'm making these recommendations. If somebody has a physical therapist, I never tell them what to do, or I will say, here's what I would do. Run these by your physical therapist. Typically, they come back and say they agreed with you or whatever.
Yeah.
But what I'm trying to do is hone my knowledge and skills so I make good recommendations. And I really appreciate you letting me bounce things
of course.
off of you in the meeting. So with that, Judy, who's been very patient, go right ahead.
Thank you, Ralph. Samantha, thank you for your presentation. It's been excellent.
Thank you, Judy.
Thank you. My question is, I'm trying to move from a 3-point walking with my cane to a 2-point. And I understand repetition in practice, and I'm trying to be very mindful. I'm just wondering if you have any other tips that can help me make that transition.
So something really helpful to kind of take your mind out of it. Oh,
no, I'm just listening.
Oh, okay. Is making instead of thinking, step with the cane, step with this, that's all very internal. Try to making it external, where if you could place something on the floor, so say you even had tape or socks, or I'm just trying to think of something that would be almost like it would give you a spotter for you to just place, okay, 1 foot, now foot and cane, like almost like a hopscotch path where you can get spotters or napkins, something. I'm just trying to think of something that's not too slippery, but something on the floor where you just know, okay, right foot goes there, now left and cane goes. Now right foot, now left and cane. Because when we bring things externally, the motor learning is better versus saying, okay, I have to step farther, step farther, step farther. If I just put a visual cue on the floor of step to that spot, I learn better. So try to bring it externally, even if it's finding cracks on the sidewalk, step on one crack with this, now try to touch with two, with the cane and the left foot at the same time. So using chalk, anything that you can try to get an external cue on the floor would be helpful for you. And I'd start there.
Excellent. Thank you.
You're
Excellent
welcome.
tip. Thank
You
you.
get some of that big fat chalk we had when we were kids.
Yeah.
You have that parking lot where you ride your recumbent bike. They're not going to arrest you for making a hopscotch grid or whatever. So you could just literally with a piece of chalk, you might have to map it out, and it'll probably last a couple of rains. You could set up your own little mini course, and based on we'll see if Samantha agrees with this. She's saying the visual is going to help reinforce. The more senses you involved in learning, the more you're likely to remember it and pattern your brain. So one of the things that I've used with myself and with other people that I've worked with is I either talk to them or have them or teach them to talk to themselves. Just say, you're left affected, so you would say, left and cane, right, left and cane, right, left and cane, right.
Yeah, speaking out loud definitely helps, because then that incorporates the auditory and the speech in it. Sometimes I even like making it a little easier. You could just say 1, 2, 1, 2, because when you say 1, it's just the 1 foot. When you say 2, or just thinking of anything that's going to make it easy for you to remember the pattern will be great.
Great.
So,
thank you.
So build yourself a little visual cue in the parking lot and talk to yourself. And my final thought, and I mean, this is not that easy, but at some point, just do it. Like Nike says, just do it. A lot of times I find that it's like this, well, I went to try and skip. Somebody said something about skipping yesterday, and I tried it again after like 10 years. I stand there, I have no idea how to start. And I haven't solved, I shouldn't bring this up because I haven't solved it. But a lot of times you have to go for it to get yourself more into that automatic thing.
Yeah, just to get moving.
That might be something you would try after you do the hopscotch 1, 2. You could also accent the 2, like I gotta move 2 things. 1, 2, 1, 2.
That's a good one.
Yeah. Or just removing the cane
I
totally.
I like how she shortened it, because I was saying left end cane, right, left end cane. It'll work, but I like the 1, 2, and just hitting the 2 reminds you that you're supposed to move both at the same time.
Yep.
Once you pattern yourself a little bit, it'll get easier. It's that the reason I brought up the skipping is it seems to be like that starting. I stand there and I go, well, what's the first move? I don't know what to do, and I'm scared. I'm scared I'm going to fall. So anyway, anybody else got any questions? I don't know what Samantha's got going on in terms of appointments and such.
Oh yeah, I could give a couple more minutes.
Okay.
Anyone has any other questions?
What, Gary?
Kelly Meekin has her hand up.
Oh, I'm sorry, Kelly.
Hello.
I'm not.
Can you hear me?
Yeah.
Okay.
Please
It's
go
been
ahead.
a while. It's been a while. Thank you for putting attention, everyone, because you got my attention. And my foot drop has returned, so this has been very helpful with your videos and talking. My question, I guess, is I know what to do now, a little bit more of my ankle strengthening and fatigue. The worst part now that I can walk is the fatigue going on 7 years, or almost 7 years, sorry. Is this common, the fatigue and strokes?
Yes, 100%, because just think your brain is hurt, right? Or it's recovered, but it still has a scar there, right? So the brain has to work harder, and the brain is really one of the only organs that's working all day, right? When you're thinking, even if you're just relaxing, like your brain is on. So it's very, very common, especially when you start pushing yourself more, that you're going to have more fatigue. If you're struggling with it, you can start incorporating endurance training, obviously, into, start really looking at your endurance to see where you're kind of having that hard block, and make sure that you are incorporating rest within your day. Sometimes it can even be helpful to move your exercise schedule to different parts of the day. So try exercising in the morning versus in the afternoon. You may have more energy then. And also discussing, if you've been on the same medications for a very long time, discuss managing medications with your physician, because side effects of a lot of medications is fatigue, especially those nerve pain and tone medications. They can lead to drowsiness. So trying to either reduce or change medications can be helpful. And also maintaining a really nice, nutritious diet will give you some better energy throughout the day. But in addition to that, just know that it is normal. And as long as you're able to manage it, you'll be able to move forward in your recovery process. You don't want it to let you hold, you don't want it to hold you back. You just have to manage it and make sure that we're incorporating it into a schedule and a good routine, so that you're able to do the newer things that you're able to do.
And rest when I can.
Yes.
One quick thing, then we'll let Stephanie ask hers, and that is, well, just say baclofen is one of the ones that makes you drowsy. If you're on it once a day, one strategy, and you talk to your doctor about this, is to take it at night. Now, of course, that doesn't work when they have you on twice a day or 3 times a day with the baclofen. And I completely agree with you, Samantha. Of course, I should. You're the doctor, and I'm not. About the paying attention to your rhythms during the day. Because, if like you're good in the morning, then you need a nap. After lunch, you need another nap, but you're good 3 or 4 o'clock in the afternoon. Pay attention to where your highs and lows are, and then try to adjust your schedule to do your exercises at the point where, at the times of day where you have the most energy.
Yeah, for sure. And spacing things out too. So, if you're having a busy morning, you have an appointment in the morning, when you come back, don't go right into your exercise. Take a little rest, have some lunch, then come back to it in the afternoon. Sometimes you need to just pace that even with, whatever else you have going on in the day. Sometimes we have, sometimes you have a really busy morning, or you have a really busy afternoon. Maybe we can flip-flop things, or just take a rest day. When you do have a longer day, hold off on the walking or the long distance walking, at least that day, and then move on to, move it to another day. So just modifications. It's never, no, you can't do something. It's just, we have to modify it to make sure that we can do it the best way that works for you.
I always overdo it and push myself too far and pay for it. I jump in with 2 feet. I ended up getting 3 years ago, I got a lab. So every day she makes me walk. So it helps both of us.
That's awesome.
Yes.
They're good buddies also. All right, Stephanie, your turn.
Thank you.
Just a quick question. I want to be respectful of your time. Do you have experience with the weighted vest?
Yes. So I love weighted vests. I think it's a great way to add intensity to any activity that you're doing. Especially the ones, if you go onto my PT Instagram for my
I'm having
practice.
trouble finding it. Can you flash up that where your company's signal?
Let me write it in the chat.
Okay.
Also, it'll be under, all our information will be underneath
in the YouTube
video in the description.
Okay.
I have a highlight on there, the top left. It's a little circle and has a dumbbell. I have equipment on there that I like. And
Okay.
if I find something good, I put it there. There's a vest on Amazon. It's a little pricier than the others, but the weights in it you can remove. So you can take them all out, or add 2, add 3, add 4. So it's nice to be able to progress and regress depending on the task that you're doing, or how, how good you're doing.
And is the weight completely circumferential and mostly?
Yes, it's in the front and the back.
Okay.
Very easy to put on. It's great for intensity of any type of rehab that you're doing. So if you're walking, it's great for that. It's good for proprioceptive input, gives you more information about where you are.
That's where I needed it. And that's what first
Yes.
drove me. And I ended up making my own, but the weight is carried around my waistline. And I just think it was too much
Yes.
for me at the time. But so I'm investigating that, but I have a better gait when I have the pressing down. So,
Yes.
and you feel like, I mean, I'm no expert at all. I know my body, but I don't want to get hurt in the process.
Mhm.
So I want to make sure what I'm doing is wise. Because like if you look up the ataxic gait, is the vests, it's like, only a certified person can do it and put the weights in and out. And so I don't want to get crazy thinking that I'm able to do.
No, you're safe to do it. Basically, they put that as to save their own butts.
Yeah,
We could discuss
and
a
I
little bit
respect that.
further
Yeah.
about it. Why don't you reach out to me so we can discuss any of your
Okay.
true concerns?
Okay.
But as long as you're moving slowly with it and you're adding it incrementally and you're not overdoing it, really listen to your body and track how you're feeling. Start slow and progress.
So there's no sort of way
program
where you do it large at the beginning and then move down as you gain ability. That doesn't make sense to you from a recovery
that
standpoint?
does make some sense, because if you're thinking about it as like from a stability proprioceptive standpoint, yes.
That's basically where I'm at.
Yes.
Yeah. Okay.
Versus if you wanted to increase intensity of something.
Right.
Then it would be the reverse.
Okay.
The main thing is, you said you're fairly aware of your body. So listen to your body. People who pay attention to what's going on with them do better than people who don't. I wanted ankle weights, and I spent twice as much and got the ones where you can take the weights in and out and adjust them. In my case, working with multiple people, it's a good thing. But in anybody's case, and if you're going to buy a device for $15, why not buy it for $30? And the vest maybe more than that, but it gives you the flexibility to do what you want to do with it for where you're at that point in time. So
yeah, for sure.
I'll have to check out that equipment page you got, or device.
Yes. I don't have too much on there right now, but I definitely have the vest. So
great. Thank you.
You're welcome. I'm going to have to excuse myself. I have a patient at 1:00.
No problem.
I truly appreciate you guys having me. I hope that what I was able to provide you with was helpful. Of course, reach out to me. I always love chatting with anyone and anyone. So feel free. You can message me on Facebook, comment, email me, whatever way is easiest for you. Feel free. Don't be shy.
Well, it was absolutely helpful, and
Thank you very much for your time.
We most certainly appreciate you taking your time to educate us, and you've engaged with the whole community as well, and that's part of what I like to do in terms of working with experts like you. I love it when they stay engaged, and if you want to keep doing these, you know where I am. And
you know it, Ralph. I'll be on again.
And for everybody out there in YouTube land, one more time, we'll put some videos that we talked about. And Samantha, if you want to even give me the links to those YouTube videos, I'll put them there in case people want to look at the videos in your presentation again on their own. We can do that. And also want to thank everybody, some who are no longer here, for coming. This was fantastic.
Yes, thank you so much. It was a pleasure.
Great information. Thank you. Thank you.
Thank you for having me. I'll talk to you all soon.
Okay,
bye-bye.
Bye-bye.
Bye.
Do all you can with what you have, in the time you have, in the place you are. Do all you can. Do all you can.